All right, so we're going to talk about lifespan development, chapter 7. So obviously our standard competencies we have to go through applies fundamental knowledge of the emergency medical service system, safety and well-being of the EMT, medical, legal, ethical issues to the provision of emergency care. And lifespan development applies to fundamental knowledge of lifespan development to patient assessment and management. So humans develop throughout their lives, as you know, starting from neonates all the way up to geriatric. And there's all different parts in between. With that, EMTs must be aware of the physical changes of a person that undergoes at various stages of life. And this may also affect the approach to the patient care. And we'll discuss more about that when we get into the pediatric and then getting into the geriatric assessment, because those are completely different than the normal adult or teenager that we tend to deal with. So obviously neonates, and these are things you're going to need to know for your exams, and testing is the age ranges for the neonates and infants, all the way up to adolescent to geriatric. So neonates and infants, neonates are birth to 1 month. Infants are 1 month to 1 year. And this is where they start developing at a startling rate. So with neonatal stuff, a lot of things change with compression ratios and things like that. So New Hampshire protocol, like we all learn CPR, we take CPR, we learn pediatrics 15 to 2, adults 30 to 2, but 15 to 2 if we have 2 people. With neonates, it's a 3 to 1 ratio, and that's within the state protocol, which they don't teach you in the American Heart or American Red Cross or anything else that you decide to take for your CPR stuff. So a lot of stuff does change in the neonatal range. The neonates they're scary to deal with, especially if you don't have a lot of knowledge dealing with neonates when they are sick. Then we start getting the infant phase from the 1 month to 1 year. With this, we're going to learn a lot about how to use Broslow tapes and things like that when we get into pediatrics. So the vital signs at birth, a pulse rate, normal pulse rate is 90 to 180 beats a minute. And the respiratory rate is between 30 and 60 breaths per minute. Shortly after birth, the pulse rate drops to 100, from 100 to 160, and the respiratory rate slows down to 25 to 50 breaths per minute. So as you can see, there's a big change from going from heart rate and respiratory rate just minutes after birth, and whatnot. By 1 year, the respiratory rate slows down to 20 to 30 breaths per minute. So you're going to start seeing these. And one of the things you need to remember about neonates is you, as an EMT basic or EMT level, it's within your scope of practice to do deliveries in the field, even without having a paramedic present. The blood pressure directly corresponds to the patient's weight. So it typically increases with the weight itself. So the way it works is for weight is neonates gain 6 to 8 pounds. Weights. Neonates weigh 6 to 8 pounds, which is 3 to 3.5 kilograms at birth. Anything that we do with neonates pediatrics, weight needs to be converted over 2 kilograms. I remember we discussed this before. You divide by 2 and take off 10%. The growth of a neonate, an infant, is about 1 ounce per day, and the weight triples by the end of the first year. So we want to make sure we're seeing good weight gain. We don't want to see kind of weight loss. So it's very important to find out the pediatrics weight and by the parents who should be getting postnatal checkups. However, if you don't have a scale in front of you or the parents don't know the weight, we utilize a Broslow tape to kind of get a rough average of what it may be for that. To kind of add a little bit to this as well is one of the there's an app that you can get for your phone, which is well worth the $5 spend, and it's called PediStat. And with that, it helps you with all your pediatric needs when it comes to assessments and medications and everything else, by going by Broslow tape, weight, or age, and it kind of gives you everything you need to know about it. The cardiovascular system at birth, neonates make transition from the fetal to independent circulation. Remember, as they're inside, they're feeding off mom. So with that, utilizing the umbilical cord to circulate blood and everything else, and nutrients to stay alive. Once they come out, that's when you see the change, because obviously we're cutting the umbilical cord and they're functioning on their own, independent. The pulmonary system, infants younger than 6 months are prone to nasal congestion. So you may see difficulty breathing. It might be as simple as taking out what I like to call the turkey baster, but a suction, and utilizing that to suction out the snots that you may find in nasal congestion within their nasal system. Infants also have larger tongues and shorter, narrow airways, so airway obstruction is definitely more common than in older children or adults. So remember back in the human body, we talked about the trachea. The cartilaginous rings are not fully developed, so the trachea is more pliable. So just by having the heavier heads, the larger tongues, and the shorter, narrow airways, by their head moving, hyperextension, hyperflexion can easily cause the trachea to start occluding as well to reduce your airway movement. As far as the nervous system goes, the evolution continues after birth. So the motor reflex, so neonates, open arms wide, that should be neuro, spreads fingers and seems to grab things at that point. So they tend to want to reach out, they want to grab stuff, they want to move around. The palmar grasp occurs when the object is placed into the neonate's palm. So what we do is sometimes what I'll do at an assessment to make sure they're actually grabbing stuff, I'll take like a pen light and I'll put that into their hand and see if they'll grasp it to make sure that we're trying to make sure we have the right grasps and the right reflexes. The rooting reflex, the neonate instinctively turns head when something touches its cheek. So you can do that as well for a neuro assessment. Or the sucking reflex is occurs when the neonate's lips are stroked. So if you stroke the lips, you should start seeing a sucking type reflex. If we're seeing these and we're testing these in the field, we're going to know that their neuro system or the nervous system is intact. The next part is what they call a fontanelle. So the fontanelle is the space between the bones that eventually fuse to form a skull. So posterior fontanelle fuses by 3 months, and the anterior fontanelle fuses between 9 and 18 months. And the infant's immune system also maintains some of the mother's immunities as well. The fontanelles are very important for us, especially doing assessments, because if the fontanelle is bulging out, that usually means there's some type of head injury or there's intracranial pressure. If the fontanelle is sunken in, we'll see that more with severe dehydration or hypovolemic pediatrics or neonates. Again, do not take your finger and start pushing on the fontanelle because that can actually kill the infant. So we want to make sure if we feel it, we rub our hands over it to kind of see if it sinks in, if it's normal, or if it's bulging out. This is where the fontanelle will be located. So the one on the top, the anterior fontanelle, that's the one that we're going to be doing our assessment on. The mastoid fontanelles and the sphenoid or sphenoidal fontanelles, we're not really going to be putting any pressure on. There's also some psychosocial changes which begin at birth and evolve as the infant interacts with the environment. So as you can look down through the list here on the noticeable characteristics, from 2 months, recognizing familiar faces and tracks objects with the eyes, when down to 12 months, where they know his or her name and they start to walk at this point. So as we're doing our assessments, we kind of want to see if they're kind of going along with the characteristics that we actually have in front of us. Some other psychosocial changes would be crying is the main method of communicating distress. So they cry for a reason, sometimes. Infants also develop relationships with their parents or caregivers at different rates. So we want to see if they're consolable. That's a big part of our assessment as well. So if a kid is non-consolable with their mom or dad, especially if they're very close to them and they're crying and they're acting out at that age, then we know there's actually a problem because they should be able to be consoled by their mother. So we want to make sure we document as well in our narratives during our assessments is, are they consolable or not? Some other psychosocial changes are bonding, which is based on a secure attachment, anxious avoidant attachment, is also found in infants who are repeatedly rejected. Separation anxiety is common in the older infants, where they don't want to leave mom or dad, and they start crying to get back to them. And trust and mistrust involves an infant's needs being met. Anytime we assess an infant, anytime we assess a pediatric, we want to start at the feet first and work our way up. So it's always a toe-to-head assessment. We'll get into that more when we talk about pediatrics. Toddlers and preschoolers, from age of 1 to 3, we start seeing our heart rates come down a little bit more from 90 to 150, and our respiratory rate from 20 to 30 breaths per minute. And then we'll start seeing a systolic blood pressure of 80 to 100, and a temperature between 96.8 to 99.6 degrees Fahrenheit. Preschoolers will see ages 3 to 6. The pulse rates start coming down even more now from 80 to 140. Respiratory rate 20 to 25, and the systolic blood pressure still stays between 80 and 100. With the preschoolers, weight gain should start leveling off until they start getting growth spurts again. Passive immunity is now lost, and the toddlers will acquire immunity as their bodies are exposed to various viruses and germs. So kids, go out and play. Neuromuscular growth also makes considerable progress at this age as well. And we also start seeing an average age of completion of toilet training right around 28 months. That should be the average for completion. Some psychosocial changes. Obviously, we're going to learn to speak and express themselves, and they start to master the basic language. Remember that kids are sponges and they hear everything that you do or say. They interact and play games with other children at this point and begin to understand cause and effect. So if they burn themselves, they know, ouch, it hurts. They probably shouldn't be doing that again. They learn to recognize gender differences by observing role models as well. Your school-age children from 6 to 12 years. At this point in time, we start seeing vital signs approach those of adulthood. So heart rate of 70 to 120, respiratory rate of 15 to 20, and systolic blood pressure of 80 to 110. They do make pediatric vital sign cards, which I do have some somewhere. If I can locate them, I will give you guys each a card on Sunday that you can hold on to for assessments. So obviously, we start seeing some obvious physical traits and body function changes become apparent at this point. The growth of 4 pounds and 2.5 inches per year. We start seeing some permanent teeth coming in, and brain activity increases in both hemispheres at this point. Some of the psychosocial changes, we'll see pre-conventional reasoning. So children act to avoid punishment and get what they want. You'll start seeing this around 5 to 6 years old, where they try to manipulate you, things like that. Conventional reasoning, so children look for approval from their peers in society. Post-conventional reasonings, where children make decisions guided by their conscience. And self-concept and self-esteem development. So as you can see, this can also become a challenge when one of these kids actually becomes sick or get hurt as well. And again, once we get into pediatrics, we'll go way more in depth in the assessments. Adolescent teenagers from 12 to 18, our vital signs level off to 60 to 100. As you know, that's the normal heart rate for any adult. The adult respiratory rate as well from 12 to 20, and it's a solid blood pressure of 90 to 110. So now, as you can see with the adolescents from 12 to 18, they start normalizing to the point where they meet the same vital signs as an adult does. They have a 2 to 3 year growth spurt. Girls usually finish growing by the age of 16, boys by the age of 18. And the reproductive system starts to mature. So secondary sexual development starts taking place. Voices start to change. Menstruation will start beginning. And acne can occur as well. So again, they're going through a lot of changes. And with this, may be difficult for a female to express some of these changes with a male provider. So a lot of times you may want to find out if there's a female provider present to kind of talk with a female, and the same thing with a male talking to a male. Adolescents and their families are often deal with conflict at this point. Privacy becomes an issue because these kids, all they want to do is be private. They want to be alone in their rooms. Parents are like, keep the doors open, things like that. Adolescents may also struggle to create their own identity at this point, and self-conscientiousness starts to increase at this as well. Now, this is where you start seeing also, and I hate to talk a lot about suicidal stuff, but when they start trying to create their own identity and they start to struggle with this kind of stuff, a lot of times this can lead based on peer pressures or bullying in schools and things like that. So it's kind of our job that if we get called for a meet the PD to check a subject out type call, where we want to make sure we're actually doing a good assessment on these patients to kind of help them get through. Sometimes they may just need another adult to talk to other than their parents. So maybe they don't feel comfortable talking with their family members. So again, we got to pick up on some of the signs that we see and the symptoms that we also pick up on as well. Antisocial behavior and peer pressure peak ages 14 to 16. So again, unprotected sex, eating disorders, smoking, illicit drug use, and yes, this stuff actually does happen. The eating disorders, where the girls think they're too heavy or the boys think they're too heavy, and they start becoming anorexic or bulimic to get down their weight. Code of ethics start to develop, and a high risk of suicide and depression. So again, we got to pick up on these signs and symptoms, and we got to get these kids treated. And again, if it's sometimes you might find it where it's easier for a female to talk to a female, a male to talk to a male. Another thing also you got to remember with adolescents as well, let's say they are having unprotected sex or sexual relations of any sort at the age of 15, you think they're going to want to let their parents know about it. So if there's a potential where you could find a pregnancy or severe abdominal pain, if you ask them, have you been sexually active, they're going to tell you no, most likely in front of their family members. So try to separate them at this point and try to get them aside alone, and they may give you the answers you're actually looking for. Early adults would be 19 to 40 years old. So vital signs do not vary greatly at all. So 60 to 100, 12 to 20. And then systolic blood pressure of 90 to 140. So we start seeing blood pressures going up the older you get. If you don't take care of yourself, that's what happens. So again, blood pressures may start to rise. From ages 19 to 25, the body should be functioning at its optimal level, what they call your peak. Lifelong habits are solidified. Your psychosocial changes, obviously life centers on work, family, and stress. You start thinking about settling down, marriage, family, and one of the more stable periods of life from ages 19 to 25. Again, all these are based on averages. You start seeing the middle adults from 41 to 60, so vital signs remain the same, 60 to 100, 12 to 20, blood pressure of 90 to 140. However, they're more vulnerable to vision and hearing loss at this point. Cancer incidence may increase. Menopause occurs in late 40s, early 50s. And then we start seeing other kind of comorbidities as well, like diabetes, hypertension. Weight problems are definitely common at this time as well. Exercise and healthy diet can diminish the effects of aging. So again, try to stay in shape, try to take care of yourself. And one of the biggest things, obviously, is eating right, drinking right, taking care of yourself, especially in this field of work that we're in, because our bodies are put under a lot more stress, dealing with critical calls to triple decker homes to whatever it may be. Some other psychosocial changes, obviously, we're going to focus on achieving life goals as well, readjusting lifestyle as children start to leave home. We generally have the physical and emotional and spiritual reserves to handle life's issues, and maybe caring for both children leaving for college and aging parents. So, again, now we're taking care of our parents, we're taking care of our kids, and things like that. So, you got to kind of look out for all of that stuff. And this is where you might start seeing your midlife crises. You may start seeing, suicidal thoughts and things like that as well. So you just got to pay attention to it. It's no different than your early adulthood and things like that. Now, the older adults, 61 and older, life expectancy is constantly changing. Now, approximately 78 years old. We're saying a full life expectancy. With this, remember, they may have other diseases. They're moving like osteoporosis, osteoarthritis, rheumatoid arthritis. Things start kicking in. Body functions are starting to change as well. Hearing loss, vision loss, so when we're doing our assessments, we need, especially with the older adults, 61 and older, we need to start speaking slower. We need to start speaking more clear. We need to ask the appropriate questions and things like that. Vital signs are dependent on the patient's overall health, medical conditions, and medications taken. So if you remember back to pharmacology, there are some medications that will lower blood pressure. They'll also lower heart rate. So if they are sick or they're hypovolemic or things like that, some things to pay attention to would be is what medications are actually on. Because if they're on beta blockers, then you might see heart rates staying more normal when really they should be more tachycardic because of the condition that they have. Older adults are often able to overcome numerous medical problems, but still may need multiple medications to do so. Whether they're diabetic, they have a low thyroid, if they've had a previous heart attack and they're on blood thinners, if they have atrial fibrillation and they're on blood thinners, a lot of different stuff that's out there. Hypertension, gastric reflux, and things like that. The cardiovascular system obviously starts to decline with age, largely due to arteriosclerosis. Heart rate and cardiac output starts to decrease at this point, and vascular system becomes more stiff. What they're saying here is your pipes have a lot of plaque inside, and your arteries your vascular system becomes stiffened. Because of this, and things start to drop, we might see potential changes as far as arteries becoming fully blocked, causing heart attacks. The ability to produce replacement blood cells also declines, as does the blood volume. So with that being said, an elderly patient could bleed out internally faster than a younger adult. The respiratory system, the size of the airway starts to increase, and the surface area of the alveoli decreases. So remember, the alveoli is where the gas exchange actually happens. Remember, air comes in, oxygen comes in, carbon dioxide comes back out, and at the alveolar level, that's where the gas exchange is happening to relieve all the bad stuff. If the alveoli decreases, or the area of the alveoli decreases, you may see other issues with oxygenation as well. The natural elasticity of the lungs also decreases. The intercostal muscles are now used more to breathe, and breathing becomes more labor intensive. So again, they may develop something like COPD, especially if they're a smoker and they don't take care of their lungs. And this will also make breathing more labor intensive and can cause chronic obstructive airway disease, pulmonary disease, for the COPD, and they may end up on oxygen at home. Aspiration and obstruction become more likely because they've lost a lot of muscle function, so they can either easily aspirate into their airway or they can have an obstruction from eating certain foods. By the age of 75, vital capacity may amount to only 50% of a young adult's vital capacity. So they may lose respiratory muscle mass, increased stiffness of the thoracic cage itself, so your chest, increased surface area available, decreased surface area available for the exchange of air. The residual volume also increases as well. So again, the lung capacity is not going to be the same. So their difficulty breathing may be a lot worse, and we may end up using CPAP on these patients at the EMT level to help get air and oxygenation to the alveoli. The endocrine system, so obviously insulin production starts to drop off. The metabolism starts to decrease. So people tend to slow down their physical activity but do not decrease their food intake. Now they start becoming heavier. Because of that, remember, and everything else, stiffening up and then also losing a lot of muscle mass, they become more obese. And the reproductive system changes to some extent as well. You might see lack of sexual desire. You may see erectile dysfunction, things like that. So again, if you have a patient who's taking erectile dysfunction medications and they have chest pain, we're going to have to withhold our nitroglycerin based upon the time frame when they last took it. Men are able to produce sperm, however, but the rigidity of their penis also decreases over time. We just talked about that. Women also decrease in their size of their uterus and the vagina. Hormone production for both sexes gradually decrease, and sexual desire may diminish, but does not cease. Taste sensations start to decrease. Saliva secretions decrease. Therefore, they become very dry, hard to swallow stuff. That's what causes a lot of the choking as well. The ability of the intestines to contract and move food diminishes. So a lot of times you'll see in the elderly patients, you'll see like small bowel obstructions or bowel obstructions because the intestines can't contract and move the food like it's supposed to. So therefore, it backs up. Another thing you'll also see as well is a lot of the elderly may be on some form of pain medication, and pain medication can also cause bowel impaction. So you may actually have more abdominal pain and then unable to poop because it's just become so impacted. Because a lot of times the pain medication will cause everything to dry right out. Gallstones become increasingly common with this, and the anal sphincter changes and can produce fecal incontinence, which we just talked about. Filtration functions decline in the renal system, so they're unable to filtrate like they're supposed to, and the kidney mass decreases by 20%. Therefore, they're not going to be able to pee as much, which means they can't filter the toxins out of the system. With this, something else to also pick up on is sometimes they end up doing Foley catheters at home. If they're doing self-caths, they have now increase the potential for infection as well. So you may see septic patients and things like that, or urosepsis. Decreased ability to clear waste from the body and decreased ability to conserve fluids when needed. The nervous system, obviously motor and sensory, neural networks become slower. We start looking at maybe neuropathy kicking in as well. So therefore, they start losing the sensation and things like that in their feet and the extremities. Neurons are lost, but there is no loss of knowledge or skill. And sleep patterns start to change as well. They could be sleeping longer or shorter times. Things tend to change with this. Age-related shrinkage creates a void between the brain and the outermost layer of the meninges, as you can see in the picture here. Other things to pick up on as well is there's Alzheimer's, dementia. Peripheral nerve sensation is also diminished. So we just talked about that and started looking at some neuropathy. Increased reaction time causes longer delays between stimulation and motion. So they may actually, they could take a burn and be on the burner for a longer period of time before they actually realize, hey, this is not good. Slowdown in reflexes and decreased kinesthetic sense may also contribute to falls and trauma. So we mentioned something about falls a couple of classes ago, where you may see an elderly patient fall to the ground, strike their head, they get back in the bed, a week later they're unconscious because they developed this slow head bleed, something that couldn't be picked up on a CAT scan initially. Also, remember, they're also more brittle when they do fall with the elderly as well, so you may have more apt for seeing fractures. And one of the common fractures you see for hip injuries is a femoral head fracture, not necessarily the actual pelvis. And we'll talk about that when we look at different assessments. You'll see some sensory changes as well, where most older adults can see and hear well. They also may need glasses or hearing aids. Visual distortions are definitely common with this, and also hearing loss is 4 times more common than vision loss. So again, if you have someone with some hearing loss, you need to speak slow and loud enough for them to be able to hear you. Now, they might say to you, hey, you're speaking way too loud, I can hear you perfectly fine. In that case, you can change it a little bit. But remember, you also need to speak slow to them so they understand what you're saying. And if you go too fast and ask too many questions, they may be saying yes to something or no to something where you need to actually have a yes or no answer for something prior to the question you asked. The psychosocial changes, until about 5 years before death, most people retain high brain function. Statistics indicate that 95% of the elderly live at home. And we go to a lot of elderly calls, whether it be medical alarm activations to family calling. Financial limits may restrict access to health care or medications, so we're going to be going to these homes where, like, well, we can't afford medications, so we take where we can. Also, not having a good caretaker at home or someone who's understanding of medications. Sometimes we go to calls where they've doubled up on their medications, so they forgot they already took it. So again, sometimes you might need to count pill bottles, you might need to count pills, and things like that. So more than 50% of all single women in the United States who are 60 years of age or older are living at or below the poverty line. The elderly need to face their own mortality, and isolation and depression can be challenges. Again, we started seeing a lot of depression, not necessarily suicidal with the elderly as much as we see depression with it. So I've seen more depression with elderly in nursing homes than I have seen outside of nursing homes just in my career. And sometimes they may just call 911 because they need someone just to talk to. So you show up with the ambulance and you walk in the home. What you don't want to do is walk in and say, okay, do you want to go to the hospital or not? Just sign here. If you don't want to go, we'll take your vital signs and get out of the way. Sometimes it might just be a simple half an hour stay, have a conversation with them, get their vital signs, help them move stuff around the house if you need to make it easier for them. I'm not saying rearrange the whole living room. But if you need to move a phone closer, you need to get them a glass of water, things like that. Just having that interaction with the elderly will brighten up their entire day because really they have no one else to talk to, especially if they're home alone. All right. So again, like I said, this will be a pretty quick chapter. So when providing bag mask ventilations to an infant, what is the most important to remember?
D.
B.
B.
All right.
I'm still going with D.
Yeah, B it is. It is important to remember that an infant's lungs are fragile. Remember, infants have little lungs. So the way to kind of remember this, if you guys all put air in your cheeks right now, that's the amount of air that's inside that can go into an infant's lungs. So again, if you overinflate, it will pop. Too forceful can result in trauma, or what they call barotrauma. So due to the large size of the infants, also put in the increased flexibility of the trachea as well. So again, things can pop. So the amount of air that goes into an infant, to kind of remember, is what you can fit into your cheeks. Currently, as an adult, is what goes into an infant's lungs. All right. So you see an infant capable of reaching out to people and drooling. She is most likely how old?
D. D.
D.
D.
D.
Right here. So the answer is actually C. About 4 months of age. We start seeing them start to reach out to people and they drool a lot. Now keep in mind that also patients, and just kind of throw this out there as part of an assessment for pediatrics, excessive drooling with a high fever and lethargy could be a condition called epiglottitis. And these are the patients that we just don't touch their airways. We'll get more into that later on. I just want to kind of throw that out there in case you come in contact with it somewhere. An infant who is repeatedly rejected experiences what type of attachment? An infant who is repeatedly rejected experiences what type of attachment?
A.
D.
C.
The answer is B. So anxious avoidant attachment is observed
I
in.
was going to say that too.
All right, let's go number 4. Why do colds develop so easily in toddlers and preschoolers?
D.
D. D.
Yeah, answer is D. All of the above. Number 5. So the pulse rate of a toddler is what?
Oh, shoot.
D.
I don't remember.
It's okay.
D.
We're going to hit these things hard when we get into our pediatric assessments anyways. So I heard D. I see C online on the chat box. So the answer is 90 to 150 for the toddler's pulse rate. Again, it's hard to memorize all these because they're so different, and there's so many different levels of what we're looking at from neonate to the elderly. A school-aged child looking for approval from his peers in society is demonstrating what kind of reasoning?
E.
A.
A.
B. So during the school-age development, children begin to develop their self-concept and self-esteem. It is a critical time in human development. Children who look for approval from their peers in society are demonstrating a conventional reasoning.
What's the difference between pre-conventional and conventional?
Let me go back. I'm hitting the wrong buttons here. I'm going to stop at 7. What was the question again? Sorry.
What's the difference, or like whatever, between pre-conventional and conventional
So more
reasoning?
the pre-conventional is going to be more of them trying to take care of themselves. Does that make sense? Versus looking out to their peers.
Gotcha.
So the number 7, self-concept is
B. B.
D.
how we perceive ourselves. So think of self being our own self. Why should you be concerned about a 16-year-old patient who seems depressed?
C.
D.
C.
D.
So the answer is C. We got to start thinking about depression, suicide at these ages. And a lot of it could be brought on by issues at school, issues at home. This is kind of a tough time in life where they feel that they have no answers. They haven't really experienced the real world yet of how to live through it. So they feel sometimes that suicide is the actual answer for it. They don't know what else to do. They're so stressed out. Number 9. So why do finances become an issue during middle adulthood?
A.
A.
Here are a lot of A's. And A is definitely the answer. And number 10, why is breathing more labor intensive for the elderly?
B.
B.
Read them all. Read everyone there.
Oh,
D.
D. I mean,
D.
D.
So you're going to see questions like this one here on the National Registry exam. So make sure you read all 4 of them before you make your final answer. So D it is.
Typically I
COPD.
found that like questions that have all of the above or none of the above, it's usually that one.
Right. All right. So any questions in lifespan? You're not going to see it.
Kevin.
What was that?
So I said I have a question for you. In the general scope of your timeline for the infant, say whatever months are reaching out, grabbing in the certain time span for that, where some kids don't develop as quick as others, we should be keeping that in mind as well while assessing?
Exactly. Yes. So again, these are more of like average ages that you're seeing on here versus what you might actually see out in the field. So like I said, everybody's different when we're doing our assessments. But yes, you definitely need to keep that kind of stuff in mind as you're doing your assessment, though, is this kid based on the average or is he a little bit different when doing your assessment? Did that answer your question?
Yeah, thank you.
Okay, you're welcome. All right, so we're going to just hammer this one here out, and then we'll be done for the night. So this is more of a medical overview of stuff. Now, keep in mind, this is an overview of getting into our actual in-depth assessments. So we start talking about cardiac in-depth, respiratory in-depth, endocrine, environmental, all these different types of medical conditions we're going to come in contact with, or medical assessments. This is kind of like an overview of all of them together and how we're really going to do our assessment itself. So obviously, competencies we have to go over is medicine, which applies to the fundamental knowledge to provide basic emergency care and transportation based on the assessment findings for an acutely ill patient. So we start talking about I like to use the reverse pyramid effect, where we have all these different signs and symptoms and testing that we do to come up with a diagnosis, which is the bottom of the pyramid, or the reverse. So we actually top it on the bottom. And that's how we do differential diagnosis. So I'm sure all you guys remember the TV show House. I'm sure you've seen it at least once or heard about it. That's kind of what we're doing, but not to that in-depth of a patient. We're taking a typical chest pain patient, ruling things out to come up with a diagnosis, and how we're going to treat it. So that's what we call differential diagnosis. We're going to go over medical overview, assessment and management of the medical complaint. Pathophysiology, assessment and management of medical complaints to include transport mode and destination decisions. Where are we going to take these patients? And what is the appropriate facility? We're going to talk a little bit about infectious disease and a patient who may have an infectious disease. Assessment and management of a patient who also may have one as well, and the awareness of. And we've all been in this field long enough since COVID came out that we know how to protect ourselves. It's definitely an infectious disease. Again, you probably won't see any of that in this presentation because this came out in 2017 when they came out with the newest edition. So, a patient who needs EMS assistance generally have experienced a medical emergency, a trauma emergency, or both. You can have a medical and a trauma issue. Traumatic emergencies involve injuries resulting from physical force applied to the body, and a medical emergency involves illness or conditions caused by a disease. Medical emergencies can be a little more challenging because if I said, hey, I just don't feel well, all right, what kind of assessment do you guys have to do on me if I say I don't feel good? A lot of questioning versus trauma, where 90% of the time you can kind of see where the problem is or understand that there's blunt force trauma and this is what could happen if you were injured. So the medical emergencies, you're more putting on your investigative hat to find out exactly what's going on with this patient because you want to make sure you're giving them the exact treatment or the right treatment that you need. So it's some types of medical emergencies or respiratory emergencies where patients have trouble breathing or the amount of oxygen supplied to the tissue is inadequate. Cardiovascular emergencies caused by conditions affecting the circulatory system. There's neurologic emergencies, which involve the brain. And then gastrointestinal conditions like appendicitis, diverticulitis, diverticulosis, pancreatitis, all those different ones that are out there. Some respiratory ones we're looking at are asthma, COPD, emphysema bronchitis. Cardiovascular ones could be heart attacks, STEMIs, NSTEMIs, so if you're non-ST elevation stuff. It could be acute coronary syndrome. It could be angina. Pulmonary embolus is respiratory, but it's also cardiovascular. Neurological emergencies involving the brain, so stroke, things like that. And then gastrointestinal conditions, which we already talked about.
Hey, Kevin.
Yeah.
I can't pronounce anything with shit, to be honest. So, are we like, is that going to be held against us?
As far as, I missed that first part.
Like, I can't pronounce anything worth shit when it comes to like these medical terms and everything. So, I can like explain it to people and tell you what it is and give you the abbreviations, but I can't actually pronounce it.
It took me a long time when I first got my EMT license 22 years ago. It was like that for me as well.
Okay.
And then over time, you pick it up, read it, learn it. If you have a hard time pronouncing it, have Google pronounce it for you.
Yeah, I've never been able to pronounce anything my whole entire life.
Yeah, no worries. We'll get you through it. It's a lot easier than you think just by sounding things out. So we have urologic emergencies, so kidney stones, kidney infections, things like that. The endocrine emergency is most commonly caused by complications of diabetes mellitus. So you start seeing diabetic issues. And hematologic emergencies, which may have the result of sickle cell disease, which you find in African Americans, to other blood clotting disorders that are out there. Immunologic emergencies involving the body's response to foreign substances. Toxicologic emergencies including poisoning and substance abuse. And gynecologic emergencies involving female reproductive organs. So some medical emergencies are caused by psychological or behavioral, so that's another whole section we're going to be discussing. And also maybe specific, especially difficult to deal with because patients do not present with typical signs and symptoms. And you got to look out for the psych ones. Psychs can be very unpredictable. Whether they're bipolar, they're schizophrenic, they're manic. There's a lot of different things we're going to get in when we talking about behavioral emergencies as its own chapter. And this kind of goes to examples and conditions, which we already hit pretty hard with these here already. So patient assessment is similar to the assessment of the trauma patient, but again, with a different focus. So instead of focusing on the MOI, which is mechanism of injury, we're going to focus on the nature of illness. We're going to look at signs and symptoms, and then what the patient tells us as a chief complaint. Case in point, one of our trucks got dispatched the other day to what they call an echo level, not conscious, not breathing. When they got on, so they're preparing for a cardiac arrest. So when they get there, CPR in progress. When they show up, the patient's conscious, alert, and oriented and agitated that they're there. So that kind of changes your whole your whole deal. What's really going on with this patient? Was he really in cardiac arrest? So again, the chief complaint, what did the patient tell you? What's going on? So we want to make sure we establish an accurate medical history. So remember your sample I kept talking about? You're going to hear a lot of that on Sunday. So signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading to illness or injury. We need to get a accurate medical history because that's going to help us with our decision on where we're going to go. Now, it has to be pertinent. So again, if they had a hangnail removed 25 years ago, that's not going to mean anything to me for the fact this person has some shortness of breath. So I want to focus more on the medical history of, do you have any COPD or asthma? Are you on home oxygen? You know, things like that. You ever had a pulmonary embolus before? You know, we're going to ask those kinds of questions. We can use dispatch information to guide the initial response, but again, just because you were called for that does not mean that's what you're going to run to when you get there. Do not get locked into a preconceived idea of the patient's condition. Injuries may distract from the underlying condition that's actually going on. One of the other points I can make with that is, just because a 23-year-old female has history of anxiety does not mean that it's an anxiety attack. If they have other signs and symptoms underlying, like syncopal episodes or passing out, intermittent chest pain, anxiety, tachycardia, and then you ask more questions like, oh, are you on birth control? And they say, yeah, I'm on birth control. I just started it. Well, what's one thing that birth control can do if you don't take aspirin on a daily basis? What do you guys think?
It can cause blood clots.
Blood clots, exactly. 100% correct. And if you cause a blood clot and it gets into your lungs, now you have a pulmonary embolus. Pulmonary embolus can kill somebody. So again, don't overlook the fact because she's 23 years old and anxious, that's actually what's really going on. It could actually be a pulmonary embolus and could actually kill this. And I bring that up because that actually happened to me, where I stayed with a patient as a patient advocate. I think I mentioned that story before. So again, just because it looks obvious does not mean that it is obvious. So assessments may be difficult with uncooperative or hostile patients. So again, if they're angry and it seems not safe, back away. Maintain a professional, calm, non-judgmental demeanor. Just because you go to that house for an overdose for the 15th time doesn't mean you go in there and start judging them. Don't label them, because you walk in and they'll say, well, they're African Americans, so they've got to be on drugs. Has to be. Don't label anybody. We walk in there, treat every patient the same way we do anywhere else. A frequent caller may have a different complaint this time. We have a frequent flyer in the area that we work in. We probably go see this patient at least once a day. Every day we get called to this location. We know it's this patient here. Okay. And 99% of the time, there's not a problem, and we get a patient refusal. But again, if people let their guard down and go, oh, it's just this person once again, and she's actually having a problem because they decide not to do vital signs because it's a common occurrence with her, or this patient, I should say, because of that, they might miss something. And then, therefore, the patient could die later on because it was just one of those, oh, well, it's a frequent caller, so let's just sign them off. The next part is scene safety. So we got to make certain the scene is safe for all of us. Use standard precautions and determine the number of patients and whether you need additional help. Okay, so do we need more resources? Do we need a paramedic response? We need more ambulances. What's going on? Then we look at the nature of illness and determine the nature of illness. And then the index of suspicion would be your awareness of the potential serious underlying injuries or illness. That goes back to the pulmonary embolus thing. Just because they're appearing to be anxious does not mean that's just anxiety. Do more of an assessment, talk to your patient, find out what's going on to be able to come up with the answer you're looking for. Otherwise, don't be a lazy EMT. Develop a general impression. Perform a rapid examination of the patient. This is going to be are they sick or are they not sick? Use visual clues to include apparent unconsciousness, obvious severe bleeding, or extreme difficulty breathing. If they're cyanotic, which would be blue around the lips or blue on the extremities, we're looking for that. Are they pursed-lip breathing? Are they tripoding? Those are all indications of severe respiratory distress. Quickly determine the patient's level of consciousness. Well, how do we do that? We use the AVPU scale. Are they alert with the A? The V is alert to verbal response. The P is alert to painful response. And the U is unresponsive. And we want to find out if they're alert and oriented, so we ask them certain questions like person, place, time, and event, conscious, alert, and oriented times 4. With this, we can ask them month, day, year, and president, whatever you want to utilize. We want to make sure that they're coherent enough to be able to make medical decisions. It also helps with our assessment and what we're going to do next. We're going to check airway and breathing. In a conscious patient, ensure the airway is open and they are breathing adequately. If they are talking to you like I'm speaking to you guys now, we know they have an open airway. We know that we're breathing okay because we're speaking in full sentences. We're going to check the respiratory rate, depth, and quality. All right. Anything that we do, whether it be checking for heart rates, respiratory rate, it would be rate, depth, and quality, or rate, rhythm, and quality. We want to make sure we look at all 3 of those. Because if they're breathing inadequate, we need to help fix that problem. Whether it be too fast, too slow, we can use a BVM to fix that. If the depth is shallow, we can help them breathe with a bag valve mask. If their oxygen levels are low, by applying oxygen, if the breathing has been affected, we can consider that by using a nasal cannula. We can use a non-rebreather, or we can ventilate for them. For the unconscious patient, make sure the airway is open by using proper techniques. And we're going to cover airway management techniques on Sunday. Whether or not we use a King airway for the unresponsive cardiac arrest, to using a oral pharyngeal airway, what they call an OPA, or a nasal pharyngeal airway, which is called an NPA. Apply oxygen to the patients that are in shock using a non-rebreather at 15 liters per minute. Anybody with difficulty breathing, even if their pulse oximeter is reading 100%, if they are short of breath, we give them oxygen. When low oxygen saturations are measured, we want to make sure we're also giving oxygen. And we'll talk about utilizing the cardiac monitor and what to look for and what they call a pleth wave. I'll show you guys that on Sunday. Make sure that it's actually an accurate reading. Unconscious patients may need airway adjuncts and ventilatory assistance with a bag valve mask. Circulation, we're going to assess in a conscious patient by checking the radial pulse and observing the patient's skin, color, temperature, and condition. So we want to see if, as far as condition goes, is the skin mottled? Is it pale and diaphoretic? Is it red? Is it warm to the touch? We want to get a good temperature. We can take a oral temp. We can take a rectal temp. We can do a tympanic temp, which is in the ear. We'll look for skin color. For an unconscious patient, assess the carotid artery. So we're going to take a carotid pulse. If there is no carotid pulse, we start CPR. If a patient has a radial pulse, by rule of thumb, they have a blood pressure of at least 90 systolic, normally. It's kind of like a rule of thumb average. And then we're going to make a transport decision. So patients in need of rapid transport are unconscious or have an altered level or altered mental status. If a patient is altered, we also want to make sure we check a blood sugar because it could be a diabetic issue. Airway or breathing problems, rapid transport. Obvious circulation problems such as severe bleeding or signs of shock is also a rapid transport. And when looking at a transport decision, where are we going to be taking these patients? Do we go to a trauma center or do we go to a local critical access hospital? A stroke center, things like that. So we're going to make a determination on where we're going to go, and do we need advanced life support intercept on the ambulance to make those determinations. So history taking, very important, especially with the medical patient. This helps us determine what the problem is or what it may be causing the actual problem that's there. So we're going to gather this gather a thorough history from the patient, any family, friends, or bystanders, depending on if the patient's unresponsive. For an unconscious patient, we're going to survey the scene for medication containers or medical devices. Again, if you see an unconscious patient and they're holding a syringe full of insulin, what do you think the problem could be? What are your thoughts?
They're having a diabetic emergency.
Exactly.
And and they might have a high blood pressure. I mean, a blood sugar.
They could. They're holding insulin. That's probably what they're doing. Motor vehicle accident, and they had a half-eaten candy bar in their hand. Check a blood sugar. They could have a diabetic emergency. It could be hypoglycemic, and they realized that it was happening prior to the incident. So that was a medical condition that caused a traumatic injury potentially from a motor vehicle crash. So you got into the.
I've actually witnessed. Sorry, I was just saying I've actually witnessed a female have a vehicle accident right in front of me because of a diabetic emergency.
Yep. I had, and just to kind of bring up, I had a patient that had a blood sugar of, no joke, it was 10. And the guy drove 10 miles because he's so accustomed to driving that same route all the time. He drove 10 miles with a hypoglycemic, pretty much unresponsive. He was altered to the point where he wasn't even talking. And he drove that far because his body is so accustomed and his brain knew where to go that he missed his driveway and crashed into a stone wall. We got dispatched for an unconscious patient, and the fire command was already starting helicopters because it was an unconscious patient. I get there, check a blood sugar, and it was 10. Give him some glucagon. Patient woke back up again. Cancel the helicopter. He's not unconscious because of a traumatic injury. So don't rule stuff out. Check everything because you never know. We want to obtain a sample history and use the OPQRST mnemonic. Who remembers what OPQRST stands for? Anybody? Anybody want to give it a shot? No? Okay. So OPQRST stands for...
Onset, provocation, or provocation, or something like that.
Keep going.
Quality, region, severity, and time.
Yeah, so when did it start? Is it a sudden onset? What makes it better or worse? Quality would be a sharp, dull pressure, things like that. Does the pain radiate anywhere? Arm, neck, back. Severity is S. That would be your scale of 0 to 10. And how long has it been going on for your time? That's the mnemonic we're looking for. We're going to record any allergies, medical conditions, and medications. Remember that some patients take numerous medications, so take the medications with you to the hospital, unless they actually have a list. And if they don't have a list, one of the best things to do, especially if the patient's like not critical, is educate them, saying, "Hey, it would really help if you had made a list of your medications. That way, if we have to come back again to pick you up for the hospital, it makes life a lot easier to have a medication list readily available." Another thing that you'll see a lot with the elderly, they'll tell you, "Oh, well, the hospital already has them on file." We still need them for the transport because you may have to give a medication that may be contraindicated because of something else they're currently taking. Or you may call for a paramedic and a medic gets on board and goes, "Where's the medication list?" Because there's medications in our arsenal that we use that we can't use based on what they're taking currently. So we got to look at all that stuff as a whole. All right. Remember tacos, tobacco, alcohol, caffeine, over-the-counter medications, and sexual and or street drugs. Another way to look at it too. Scan the scene for clues about the patient's medical history. If I don't know what's going on with this patient, I look around and try to see what I can see. Again, looking at pill bottles laying around. If I see a pill bottle open laying on the ground with a couple pills around it, and I see an unconscious patient, I'm thinking maybe an overdose. Let's take a look at the pill bottle and see how many are supposed to be in there and when it was last filled, and how many they're supposed to take per day. You look at all that kind of stuff on the bottles and say, oh, well, there's supposed to be 60 in here. They got her filled yesterday and there's 2 left. All right. My assumption to this is possibly an overdose. Then I do more of an assessment, look at pupil response, things like that, to kind of determine what's really going on. So we want to make sure we scan the scene. Your secondary assessment may occur on scene or en route to the hospital. In some cases, you may not even have time to get to your secondary assessment. Because if you're stuck on trying to fix ABCs, your secondary assessment doesn't even exist. You're trying to fix airway, breathing, or circulation. Your physical examination, obviously, all conscious patients should undergo a limited or detailed physical exam. For the unconscious patient, always perform a secondary assessment of the entire body or a head-to-toe examination. So we have our rapid assessment, then we have a detailed assessment. The detailed just takes a lot longer. It takes 5 to 6 minutes going down through the body to see if we've missed anything on our rapid. Our rapid assessments during our initial is really there to gauge on picking up any life-threatening conditions, something that we need to stabilize right away. Major bleeding, femur fractures, things like that. The medical side of stuff, chest pains. We're looking at blood sugars if they're unresponsive to see if we can call for a medic to help fix those types of incidents. We want to make sure we examine the head, scalp, and face. So as we're examining this, and again, we'll do more of this on Sunday, we're going to palpate the entire head. This is your secondary assessment. We're going to feel all the facial bones. We're going to check the scalp for any kind of deformities, contusions, any kind of abrasions. We're going to examine the neck very closely because we're looking for 2 things in the neck: tracheal deviation and jugular vein distension. All right? So jugular vein sticking out, or the trachea starts to deviate. Is the trachea midline? We're going to assess the chest and abdomen. We're going to palpate all the ribs on both sides. Make see if there's any fractures, any kind of movement. We're going to put our hands on both sides of the chest. We're going to let them take a deep breath in and out. Look for equal chest expansion, so what they call equal rise and fall. We're going to check lung sounds in all fields. We're going to assess the abdomen in all 4 quadrants. We're going to palpate the legs and arms. We're going to go all the way down to the hands and feet. And then at the hands and feet, we're going to make sure they have good CSM, so motor function, sensory, and good pulses as well, circulation. We're also going to then examine the patient's back. We're going to check the spine if it's a trauma issue. We're going to start from the cervical spine all the way down to the coccyx, right down through. We're going to assess vital signs. We're going to assess the pulse for rate, quality, regularity. Is it irregular? Is it regular? We're going to identify the rate, quality, and regularity of the respirations. We're going to obtain initial blood pressure and consider obtaining a blood glucose level and pulse oximetry reading as well. I'm not saying check a blood glucose on everybody, but the patients that require blood glucose assessment are the ones we should be checking it on. And then we're going to get into our reassessment, which is performed once the assessment and treatments have been completed. So anytime you do something, you want to do a reassessment to make sure your treatment is working. This begins and continues throughout transport. And then you're also going to consider the need for ALS backup. Any intervention you do, you want to make sure it's working or not working. That's part of our reassessment. And we're also going to document any developed changes. All right, so once we get all this stuff done and we're getting in the back of the ambulance, we need to manage transport and make a destination as well. So most medical emergencies require a level of treatment beyond that available in the pre-hospital setting, which may require advanced testing available at a hospital, whether it be lab work, CT scans, x-rays, things like that. Maybe beyond the scope of practice of the EMT to administer medications to a patient, or remember EMTs can use the AED as well. Most cardiac monitors now have AED functions built into them anyways, unless they've been disabled. So you have that ability for an AED. Scene time may be longer for medical patients than for trauma patients. What we want to look for, and what we do here at Action Ambulance where I work, is we look at a 20-minute on-scene time. Anything longer than 20 minutes for all levels, we actually have to explain why in our narrative, why we were there longer than 20 minutes. We want to gather as much information as possible to transmit to the emergency department what we're going to give them. Remember, critical patients always need rapid transport, very old or very young. If they're critical, we need to get them to a hospital. That's definitive care. If you call for a paramedic intercept and they don't meet up with you or they're not available, then your closest ALS may be the hospital. Type of transport, obviously life-threatening conditions or lights and sirens. Non-life-threatening conditions consider non-emergency transport, so no lights, no sirens. Modes of transport ultimately come in one of two categories, either ground or air. So it could be either one that it could be going by. And your air medical transport, again, depending on your location, you may have to fly a medical patient. If they're having a heart attack and your closest cath lab is catheterization or PCI center is 2 hours away from you, maybe calling for Life Flight or DART coming over to pick up the patient may be in the best interest of the patient. Remember, helicopter transport is not just for trauma. It can also be used for critical medical patients as well. If you take a STEMI or a heart attack to Memorial Hospital in North Conway, they are going to call for a helicopter to transport that patient to Maine Medical Center because they need to get to a cath lab within 90 minutes of the time onset of the chest pain. So again, time's at essence with these patients. Ground transport EMS units are generally staffed by EMTs and paramedics. And air transport EMS are usually staffed by critical care transport professionals and paramedics. So air medical transport usually has a critical care nurse and a critical care paramedic on board. And a lot of times they also carry blood products as well. So your destination selection generally is the closest hospital should be your destination. However, if you call for a paramedic, a lot of times things can be bypassed based on local protocol. At times, the patient will benefit from going to another hospital capable of handling his or her particular condition. Most hospitals, if not all hospitals that I know of around here where I work, and even working in Maine, the years I did in Maine, all hospitals can handle strokes, at least the initial part where they get the CT done and they can start something called thrombolytics. And then they ship them to neuro centers, whether it be Maine Medical Center, or Portsmouth Hospital, Dartmouth, or things like that. Versus heart attacks, where local hospitals, and I'll use like the ones I've worked in, Sanford Hospital, they can't handle heart attacks. They can start treatment by giving something called TNK. They also give Plavix. They can start heparin and things like that, but they can't go in and remove a clot. So they'll ship them to PCI centers like Maine Medical Center, Portsmouth Hospital, Wentworth Douglas, and things like that for our areas that we cover it. All right, so any questions up to this point at all?
I'm good.
Good?
I'm good.
All right, so general assessment principles for infectious disease. Approach like any other medical patient. Get a scene size up, standard precautions, and complete primary assessment. Remember gathering history using your OPQRST to elaborate on the patient's chief complaint. Depending on the infectious disease, hopefully you know more about it before you come into the situation. Whether or not you have to wear N95s, if you have to wear PAPRs, whatever you may carry on in your service. But again, with today's world, at minimum, we're going in with a surgical mask, gloves, and eye protection of some sort, at minimum anyways. We also want to obtain a sample history and get a set of baseline vitals and ask whether the patient has recently traveled or have come in contact with someone who has. So remember, that was huge back then when COVID first started, was if you had any recent travel. And again, those questions have been asked by the ER even prior to COVID even being in existence, or should I say COVID-19. COVID has been around for a long time. COVID-19, obviously 19. So again, recent travel is an important question to be asking. Remember, it might not even be COVID. It could be something actually completely different. We're just so focused on COVID now that we forget there's other diseases out there like tuberculosis. That's also a respiratory condition, which is very contagious. We're going to focus on any life-threatening conditions identified by the primary assessment. Be empathetic and place the patient in a position of comfort on your stretcher and keep them warm. And utilize our standard precautions. Remember, we have gowns, we have masks, we have face shields, we have everything you need in the back of an ambulance to protect yourself and protect your lungs and everything else. Epidemic and pandemic considerations. Obviously, new cases of a disease in the human population substantially exceeds what is expected. That's an epidemic. A pandemic is a disease outbreak that occurs on a global scale. COVID. Big one for a while was influenza, an animal respiratory disease that is mutated to infect humans. I can tell you honestly, working in the emergency department last flu season, I think I saw one case of the flu the whole winter. It was all COVID-related stuff, not flu. Those with chronic medical conditions compromise immune systems, so patients that are on chemo as well, and those are very young and are very old are most susceptible to complications of influenza. I think influenza is going to come back eventually. Transmitted by direct contact with nasal secretions and aerosolized droplets from coughing and sneezing by infected people. Because we've all been wearing masks, we protected ourselves from influenza A and influenza B pretty well. The H1N1, remember when that was big? The swine flu, present for years in animals, initially identified in 2009, which caused many deaths, and we have an increased awareness of routes of transmission by that point. Again, we don't see H1N1 or swine flu hardly at all now anymore. For other diseases that can be passed on by respiratory route, always wear PPE, gloves, eye protection, and HEPA filters, respirators, N95s, or PAPRs, or cappers, whatever you want to wear. Place a surgical mask on all patients with suspected or confirmed respiratory disease. Nowadays, if you have a patient in the back of your ambulance, whether they're vaccinated, non-vaccinated, doesn't really matter. They get a surgical mask now. And hospitals won't even let patients into the ER unless they have a mask on board and on them as well. Annual influenza immunizations is important for EMS personnel to protect providers and patients. So again, get your flu shots. And obviously, get vaccinated as well. And all of you guys know about the Maine EMS ruling, right? Or the state ruling now that if you're an EMS provider in the state, you have to have the vaccine now. I'm sure you guys all saw that.
Yeah.
Yeah.
New Hampshire does not require it yet, so, but Maine does.
Well, hopefully he won't push that through with any luck.
All right.
So, question on that. If we do end up becoming EMTs like in New Hampshire and we don't have the vaccine, are we going to be forced to get it to maintain our license?
No, not in New Hampshire, no. In Maine, yes, you have to have it in order to practice in Maine.
But I mean, if they change the rules in New Hampshire?
If they change the rules in New Hampshire and they follow what Maine did, then yes, you're going to have it, or else you can't work as a provider.
Okay.
So I'm hoping that they don't and still leave it to choice of their provider. It's a choice of the person, but we'll see. I mean, I'm pro-vaccine, but I'm also pro-choice. You should be able to have your own choice if you want it or not in your own system. But again, sometimes the government can overrule that kind of stuff if you want to work. That's a whole separate topic on another day. So the next one is herpes simplex, which is a common virus strain carried by humans. Of individuals carrying the virus, 80% are asymptomatic, which means they have no symptoms. Symptomatic infections cause vessels that appear on the lips or genitals. This can cause more serious illness in susceptible patients, and the primary mode of infection is through close personal contact. So again, protect yourself. It's no different than drawing a blank. Conjunctivitis, very contagious. So make sure we're wearing proper eye protection even for that kind of stuff as well, and gloves. HIV infection, obviously EMTs face a risk for exposure, and there's no vaccines yet that exist. AIDS can still be fatal, however, with treatment, patients can expect a near normal lifespan. It's not very easily transmitted in the work setting, so your risk of infection is limited to exposure to infected patients' blood or bodily fluid. So again, EMS, we're providing you with all the appropriate equipment to wear. If you choose not to wear the equipment, you're opening yourself up for a route of exposure. And with all the needleless systems nowadays, or protective needles that we're utilizing, even up to ALS levels, the chances of getting stuck with a needle are very slim if you follow the appropriate techniques. Many patients with HIV show no symptoms at all. Always wear the proper type of gloves. Take great care in handling and disposing of needles, and cover any open wounds that you may have. If you think a patient's blood or secretions may have entered your system, seek medical advice, notify your infectious disease officer, because you need to get tested right away. And then you can also start certain treatments as well if it's caught within the first 24 to 48 hours. Hepatitis is inflammation and often infection of the liver. If they have any kind of liver disease, you'll see early signs of loss of appetite, vomiting, fever, fatigue, sore throat, cough, muscle and joint pain. Some of your late signs will be jaundice, so yellowing of the skins. Some of the first thing you'll see, obviously, will be yellow, where the whites of your eyes will start turning yellow first. You'll start seeing right upper quadrant pain, and that's exactly where your liver is located, is in the right upper quadrant. You'll see toxin-induced hepatitis is not contagious. So you can have liver failure, or acute liver failure, or acute hepatitis. There is no ways to tell which hepatitis patients are contagious. And vaccination of the hepatitis B vaccine is highly recommended for EMTs. It's not a requirement, it's only recommended. If you choose not to get it as an EMT, you can sign what they call a waiver or a declination. If not, since it's a requirement to the state, if you want to have it, rephrase that. It is required by the state to offer it to you as a provider if you're working for a service. It is a 3-shot series that it is done. And again, services have to pay for that if you work for somebody. And here is the characteristics of hepatitis. And honestly, I can't even read the screen, it's too small. All right, meningitis is another one. And this is something you really need to be careful of. Also very, very contagious, which is inflammation of the meningeal coverings of the brain and spinal cord. So signs and symptoms would include fever, headache, stiff neck, and altered mental status. So one of the things you can do is have them touch their chin to their chest and see if they have any neck pain by doing that. That can also indicate meningitis as well as one of your signs and symptoms of your tests. The most forms of meningitis are not contagious. So the meningococcal meningitis is highly contagious, though, if you have that. So take standard precautions. Again, meningitis can be treated in the ED with antibiotics. And after treating a meningitis patient, you need to contact your employer health representative, because if you come in contact with this, you may also need to start taking some medication and treatments as well. It also needs to be logged and documented, so if something happens down the road, you can be covered that way. But again, proper PPE and protect yourself. Tuberculosis, many infected patients are well most of the time. This is an airborne disease. This is why N95s were initially kept on the ambulances. So it's a chronic microbacterial disease that usually strikes the lungs. So every year, services usually require what they call a TB test, where they implant a fluid underneath your skin, and usually within 48 to 72 hours, if it comes back normal, which means you won't have like the red blotches around it, you don't have TB. And if you do come back with that or have been infected with TB, every year they're supposed to be able to offer you a chest x-ray to see if there's been any changes. Patients who pose a high risk almost always have a cough with this. Consider respiratory tuberculosis to be the only contagious form. N95s or HEPA masks are required to stop droplet nuclei. So again, if we're coming in contact with a patient with tuberculosis, or we think they may have tuberculosis, we want to make sure we're wearing N95 masks. Also wear eye protection as well. And these are the questions you want to ask. Have you done any recent travel, especially to third world countries as well? Infectious agents can take hold in some patients much more easily because of reduced defenses, like the elderly patients or people who are immunosuppressed from chronic illnesses, cancer treatment, or organ transplants. Absolute protection from the tubercle bacillus does not exist. So one third of the world's population is infected with tuberculosis. The vaccine is rarely used in the United States. We don't really get the tuberculosis vaccine. Mechanism of transmission is not efficient for that. So have tuberculin skin tests regularly. Preventative therapy is almost 100% effective. Again, that's your tuberculosis or TB test they offer on a yearly basis. Whooping cough is also called pertussis. Most affects kids and younger than 6 years of age. Symptoms include fever and a whoop sound that occurs inhaling after a coughing attack. So the best way to prevent exposure is to become vaccinated. And so what we do is we place a mask on the patient and yourself. Again, we're already wearing masks nowadays anyways. And we don't see a lot of whooping cough anyways in the field. I've rarely seen this. But again, nowadays where a lot of parents aren't getting their kids vaccinated, you have a potential now of this coming back. Methicillin-resistant Staphylococcus aureus, otherwise known as MRSA, is a bacterium that causes infections and may be resistant to many antibiotics. If patients have MRSA, sometimes the antibiotics that are there are more resistant. They have to go to a heavier hitter as far as an antibiotic. In the healthcare setting, MRSA is transmitted from patient to patient by healthcare providers' unwashed hands. So again, hand washing is very, very important. The last thing you want to do is bring MRSA home. So factors that increase the risks of MRSA would be antibiotic therapy. So patients that get a lot of antibiotics may become resistant to the antibiotic and they have to go to something even stronger. Prolonged hospital stays, a stay in an intensive care or burn unit, exposure to infected patients. These are all the ways of increasing the risk of getting MRSA. MRSA results in soft tissue infection, so localized skin abscesses or in sepsis in older patients. And a lot of times they'll know whether it's like a respiratory type MRSA, whether it's a wound type MRSA. So if you're doing inter-facility transports, that's one question you definitely want to ask them if they have MRSA, and if they do, where is it and is it under control? So you can protect yourselves. Global health issues. So the Middle East respiratory syndrome, so coronavirus. So first human case discovered in 2012 in Saudi Arabia. So look at coronavirus. Again, this is something that's been around for a long time. It's just the COVID-19 strain was a lot worse. So common patient symptoms include high fever, cough, muscle aches, vomiting, diarrhea, and in some cases renal failure, respiratory failure, and then death. There's no cure or vaccines, they say, for this virus at the present time. But again, now we're starting to see vaccines to kind of help with this. Everybody remembers Ebola when that came out, right? The Ebola outbreaks. So 2014, the outbreak of the Ebola virus in West Africa. The incubation period was 6 to 12 days after exposure. I remember when that came into the U.S. and we started getting the Ebola suits. Remember those at all that have helped out in fire departments? They put Ebola suits on all these. There's full encapsulated, almost like level B hazmat suits. Symptoms may not appear for as long as 21 days after the infection. Symptoms include watery diarrhea, vomiting, fever, body aches, and bleeding. And the fatality rate can be as high as 70% if treatment in an ICU is not initiated promptly. So again, I haven't even heard of any Ebola cases in many years in the US. So travel medicine. So you must be aware of travel-acquired infections when assessing a patient who is recently outside the US. That's why it's important to ask that question, have you recently traveled? Now that travel is back open again, that's a question we need to start putting back into our questioning. Patients can present with a variety of symptoms with this, and when you encounter an ill patient with a recent travel history, place a mask on the patient and gather as much information as you possibly can. Some important questions to ask is, where did you recently travel to? Did you receive any vaccinations before your trip? Were you exposed to any infectious diseases? Is there anyone else in your travel party who is sick? What types of foods did you eat? And what was your source of drinking water? So in conclusion, an assessment and treatment of a medical patient can be challenging and interesting because of the nature of medical conditions. So remember that the condition of a medical patient may not be as apparent as in a trauma patient who is in treatment may not be as straightforward. Some patients sometimes have more than one isolated problem. They could have chest pain, shortness of breath. They could have other things like that. And we'll get more to those later on. So on a review, a seizure patient is having what kind of medical emergency? So seizures activate in the brain, right? So what kind of emergency is that?
C.
C.
A lot of C's. So C is the answer. Neurologic. If an injury distracts an EMT from assessing a more serious underlying illness, the EMT has suffered from what?
A.
A.
A it is. Tunnel vision. Right? You don't want tunnel vision in EMS because it might put you down the wrong pathway. If a frequent flyer calls 911 because of a suspected head injury, you should never do what?
C.
C.
D.
D.
B.
The answer is C. As you can see, a lot of those seem right. Again, it's the best out of all of them. Number 4, if your medical patient is not in a critical condition, how long should you spend on scene?
B. B.
B.
So in this case here, it's D. In many cases, the time on scene may be longer for medical patients than a trauma patient. You don't want to stay on scene for 3 hours either. So you want to gather. This is kind of a horrible question to be putting up here anyways. We try to shoot for 20 minutes. That's kind of our goal, and as a street goal, to get the patient out of the house. But as long as it takes to get the information needed. Your patient is having respiratory difficulty and is not responding to your treatment. What is the best method of transport?
B.
B.
All right, B it is. When assessing a patient with an infectious disease, what is the first action you should perform?
A.
A.
All right, a lot of A's. A it is.
A.
Your patient believes he has hepatitis and is now experiencing signs of cirrhosis of the liver. He is most likely has hepatitis A, B, C, or D.
C.
C, cirrhosis of the liver in 50% of the patients is chronic hepatitis C. Your patient is complaining of a fever, headache, stiffness of the neck, red blotches on his skin. Is most likely
D.
It's
D.
A.
D. It is meningitis. The stiffness of the neck. It would be the indication for the meningitis part of it, other than fever, headache, and altered mental status. It's that neck stiffness.
Red blotches trip me out.
Yep. What should you do if you are exposed to a patient who is found to have pulmonary tuberculosis?
B.
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 B. Get your TB test. And number 10, all the following are factors that increase the risk for developing MRSA, except
D.
D.
E.
D.
D it is. Perfect. So again, this recording will be up hopefully tonight on the YouTube channel. Remember, class 9 o'clock Sunday. Make sure you dress appropriately to be indoors but on concrete floors. To move around, we're going to be doing airway, patient assessment. We do have some helpers, obviously, any calls pending. The address is 570 Plains Road, and that's in Tamworth, New Hampshire. The base is not labeled, just so you guys know. So it is 570 Plains Road. Big garage, big bay that's sitting there. When you get there, please park out behind the building. There's no parking out front unless you're an employee. So park out back, plenty of room out back to park. I will be there around 8 o'clock or so. If anybody wants to get there a little bit early, I'll be setting stuff up. If you have any payments that are due for your second payment, please bring them with you. If you don't want to mail them out, please have them with you for that Sunday so I can collect those. Also, don't forget, I also need in writing your availability to start clinical rotations. So I want to get you guys in as soon as possible. We have a lot of new hires we're bringing on board that also need FTOs. So I want to make sure I can schedule you guys around that. And we have 2 paramedic programs that are coming through as well. So other than that, that's all I have for you guys tonight.
Kevin, would the address come up in the map as Silver Lakes, New Hampshire?
Yes.
Okay.
Yep. It's just one of those weird things. So you might overlay. But yes, 570 Plains Road, otherwise known as Route 41. So my guess, since you guys are all coming from either like the Sanford area or whatever, most of you are coming from Waterboro, that direction, you're going to be coming up Route 16 north, and you're going to take a right onto Plains Road, which is Route 41, right by White Lake Pizza. And then just keep following that down. It'll be on the right-hand side. Unless you're coming up 153, but they might send you down 25 and around, so it depends.
Hey, 153. I was on that the other day. We're putting a house in Madison.
There you go. We're not far. The Madison town line from our base is literally like 30 seconds. So.
Oh, is it really? Oh yeah, I've been up there twice this week already then.
That's all. I mean, that's all I have for you guys, anyways. Just be ready for Sunday. We're probably going to be there for the full 8 hours. I know some of you have already told me you need to leave a little bit early because of work and things like that. We'll work around it, but I want to get as much assessment time in as possible to prepare you guys. So again, just be ready to work.
Okay. Have a good night.
All right. Have a good night. Thank you.
Thank you.